I'm the program director of the Mood Disorder Center at the University of Iowa. We started about a year ago after several years' realization that something needed to happen to get mood disorders sort of on the map here in Iowa City. Dr. Jess Fedorowicz is the director of the center. He's also our medical director, which means he's a psychiatrist in charge of the things that we do. And he'll tell you a little bit about his role and what we are going to accomplish together as a team. But let's start sort of in the beginning here. So if we're looking at some of the history at the University of Iowa, so why are we opening this center now? What led us to this point? Why the University of Iowa and not somewhere else? And we can go all the way back to the mid-1900s, where Paul Huston started looking at using ECT for mood disorders. We move into Martin Gall, who looked at some of the molecular levels of mood disorders and serotonin and how those changing levels affect a person's mood. We've got Drs. Tana and Winokur looking into the genetics of depression starting in the 1970s. Dr. Winokur then received an award for the studies of genetics in depression. Dr. Bob Robinson in the last 20 years started looking at how we can treat depression post-stroke, which is a bigger issue now that we have more and more people entering into the upper echelons of the aging. And then finally, we've got Dr. William Coriel, 1980s to present, who some of you may know, some of you may not know. He's kind of been around forever. And he is looking at the natural course of mood disorders and how do they start, how long do they last, and he's also been pretty instrumental in understanding, or in helping with the DSM changes so that the criteria for diagnoses can be more specific and also more applicable to people who are suffering from mood disorders. So what are we trying to do at the University of Iowa? Well, at the University of Iowa, we know that mood disorders happen in a lot of different ways. They happen to people due to biological issues that are underlying. They happen due to psychological issues as well. And in order to address something that's so diverse in the way that it presents itself, we have to address it through multiple different avenues. And some of the things we're doing are educating the providers of mental health care, so within the hospital, what residents are going through our system that we can make sure that they understand mood disorders. Jess talks about how people often believe that mood disorders are sort of the bread and butter of psychiatry, and everybody kind of knows what they are, but very few people really specialize in them. And they're the most common thing that we come across. Why aren't we doing more for the people that are taking care of patients with mood disorders? Patient and family education, this is where it's sort of a new territory for us. We often rely on community providers like NAMI, DBSA, Foundation 2 up in Cedar Rapids. A lot of the community providers do a lot of this education stuff, and so we want to partner with them on these things. And we want to find opportunities to bring in the experts to augment the education opportunities that are there. We have psychotherapy components. Some of that is clinical trial based. Some of that is just having providers that specialize in mood disorder treatment. Somatic treatments are the medications that are being used, making sure that we are across the board in all parts of our department and hopefully someday across all the university. We are having providers who are trained in using the correct medications for the correct diagnosis and even within the nuances of those diagnoses. And then research is always the missing piece, right? So research is what keeps us moving forward and helps us understand what's next. It is hard to do in patients that are mentally ill. It is hard to do in healthy patients. It is just hard to do in general, but we've been doing it for a very long time, back to the 1940s. And so we're really well poised to be able to do more of it and to be able to do it better as we go. So those are sort of the general approaches that we're taking. If there were pillars that we're kind of assigning our time and efforts to, those are the ones. I'm going to give it to Jess to talk about the people. And I apologize for the frenetic nature of this scene, but what I wanted to do was show you that there are a lot of folks at the University of Iowa who are doing something related to mood disorders, and some of them are in the background, some of them are in the foreground, but all of them and many more are doing a lot with mood disorders.
Yeah, so as you can see in the picture, and many of you may know, there are a lot of people that are doing work in mood disorders at the University of Iowa, and one of the goals in forming the center is to try to get that more integrated and working together more rather than all separated. And so many of the projects that Amanda and I will talk about later that we've taken on early on are things that may bridge across not only sections of the department at the University of Iowa, but also into the community and for those that are interested, such as we'll be talking about a support group that we have up and running. I've started as director of the center in July, and so this is just my second month. Jimmy Potash, our former chair, who is he pictured there? He's not. He's left to take over his chair at Johns Hopkins, but he had started the center. We have Scott Temple here, who does work in psychotherapy, and he's a special focus in psychotherapy in oncology, and so he works with individuals with cancer, and actually just published a book in the past year about cognitive behavioral therapy for those dealing with cancer. Bill Coryell was mentioned on the slide earlier. Bill has done a lot of work with the long-term course of illness, prognosis, and mood disorders. He was the investigator on the collaborative depression study that ran for some 31 years, and where we followed people with weekly ratings of mood and other assessments that really gave us a better understanding of individual variability in course of illness, predictors of prognosis, and the like. Don Black is our residency program director and works on the inpatient mood unit, which is one of the services that we've offered at the university, and that we're working to build bridges with to other services, such as our partial hospital program, which is led by Dr. Eric Epping. We have 3 tracks in our partial hospital program, and one of which is a mood track, and so we're working on trying to bridge the inpatient to partial better. John Wemme is doing is a basic science person who's been branching out into what we call translational research. And so the idea with translational research is there's been all sorts of progress in the basic sciences, but not a lot of that progress has made it to patient care. And so trying to bridge some of that progress forward. And he's been doing some imaging work, brain imaging work in bipolar disorder with myself, Gary Christensen in the College of Engineering, and Vince Magnotta in the Department of Radiology. Ginny Willauer is a geneticist, and her focus has been on genetics, particularly related to risk of suicide, which is particularly interesting since a lot of genetic studies have really focused on these specific sort of disease constructs or specific disorders, and less so on specific risks or outcomes that can happen with them. Kiwan Nam and Jim Beagley are involved in our ECT clinic, which serves folks that are inpatient, but also several outpatients. There are many folks that respond to ECT that then need to stay well and prevent relapse, and some of those individuals receive treatment as an outpatient. Aaron Bose is an exciting new addition to the department. So he did his MD PhD here. So he studied as a scientist and a physician at Iowa, and then was gone to Harvard for some time, where he did a neurology residency and then a pediatric neurology residency, and then after that did a 1-year fellowship in transcranial magnetic stimulation. And so he is leading our new RTMS clinic. Yes? That's true. Yeah, that's true. It is now covered. It is covered, though, only specifically for major depression. It is not covered for other diagnoses at this point. And actually, several folks, including Jim Beagley, were involved in lobbying to get that covered. For some reason, there were some regions in the country where it was covered and others where it was not, and we were one of those regions until literally, I think, within about the last year or so. So this is a relatively new development in the state and a new treatment option. They're also doing with Aaron's expertise, we're doing some interesting research in TMS. So right now, the clinical protocol is in a specific area of the brain and a relatively specific stimulation pattern, but they're doing some pretty cutting edge stuff in other conditions, including schizophrenia, bipolar disorder, and major depression, and looking at stimulating different areas, including the cerebellum, which is pretty novel. I don't know of anywhere else in the country or the world that's doing that sort of work right now, and so that's kind of neat stuff. But again, that's for research and that's not ready for prime time yet, but those are some things that we're working on developing. Yes, and so he did a TMS fellowship at Harvard and then came here and is now running that clinic. He started with one machine to do TMS, and essentially when folks are doing it, it's an, yes? So ECT is electroconvulsive therapy, and so that essentially involves inducing a seizure while someone's under anesthesia so that they don't experience the physical manifestations of that, with the idea to try to treat the illness. And we tend to use this for folks that haven't responded to other treatments. And that magnet, or the machine was essentially has been booked. So it's an hour, when people are in treatment, it's an hour a day for about a couple weeks. And so we can do about 8 people at a time. And because we've been full and we're interested in also doing research, the institution has funded another machine. And so there's one now that's fully clinical and one that's more research oriented. And so that we can kind of be doing both things at the same time and not taking turns with it. And so that's pretty exciting, and that's a pretty big investment that the university has made in that program. Kim Hart is leading the development of psychological therapies for individuals with mood disorders. And one of the things we're working on trying to get set up within the next year is specific closed psychotherapy groups. And so this would be where a group would, say, run for 8 weeks or 12 weeks, and everyone starts at the same time and ends at the same time. That's what I mean by closed. So not that no one can come to it, but it would be open to anyone in the community that's interested. And then we will do like special offerings. And so our thoughts is potentially doing a special offering in acceptance commitment therapy, cognitive behavioral therapy, or behavioral activation, or whatever it is. We're hoping to roll out our first one this year and then to try to build from that and have more of these sort of special offerings, discrete groups for folks that are interested in developing new skills, and where you would learn that during that set period, like taking a course almost, where you know, during this 12 weeks we're going to be working on this. Yes?
One of the special offerings, you're going to be looking into EFT, emotional freedom technique?
We haven't looked into that, but if you have suggestions, our contact information is on. We're looking at generating ideas for things that the community is interested in, and so by all means feel free to send us some information on that. And the key is finding someone with expertise in it and then getting it set up, but we're interested in doing a variety of sort of more special offerings. And eventually maybe something that's more long-term, but right now our thought is that giving people the opportunity to pick up discrete skills during a particular period of time that they're interested in that. And Kim is leading those efforts. Yeah. You met Amanda, who is the muscle behind the entire center. And so, as you may have already gathered, Amanda has a lot of energy, and she's been making a lot of these ideas and things happen. So please send these and other ideas to her and I. Carolyn Turvey is doing research in psychotherapy and as well as health systems. Ristina Kaliva and Scott Stewart are both involved in women's health, and we've had a women's mental health service that's largely focused on postpartum mood disorders, and we're working on trying to build bridges with them since they've been largely independent. Andrew Pieper does research in basic science, and he's been working on developing new molecules that can be used as potential treatments. And so it's sort of very interesting stuff. So one of his compounds that he's developed these compounds that appear to be neuroprotective. And he does these in kind of a neat way. And so he has this animal model where he looks at regeneration of neurons in the hippocampus. So that's a part of the brain where we know that neurons can grow and develop and regenerate. And he puts pools of compounds into these models to see if anything in that pool appears to be stimulating. And they're pools of like 50 compounds. And then if one of those pools looks like it's promising, then he figures out which compound in the pool is doing it. And he's found actually several. And one of his was purchased by the Calico, which is the drug company that Google sprung off, and it's now since been dissolved from that and is going in a different direction. But he's been developing several new compounds that may eventually become treatments for a variety of neurological and neuropsychiatric conditions, which is fairly exciting. And then we have Amy Grishala here. She is a medical student who works in my lab, who has been an active patient advocate and is going to be leading a group that we're starting for a support group for individuals with bipolar bipolar disorder and depression, and this group is starting with their first meeting on Sunday, and so we're excited to be supporting that and getting that going. She had just completed a week training in Omaha this summer to lead these groups, and so we're hoping to really have that take off, and I think Amanda will be talking about that later. So anyhow, so there's a lot of exciting things happening. What we're trying to do is to coordinate them better, integrate them better, and expand. And I think are some of the other things on later slides into? Okay, sounds good. Should I pass it back to you?
Sure.
Okay, great, thanks.
So Jess talked a lot about some of these things that are happening and gave probably a better scientific explanation than I can give as a social worker. But these are the current research agendas or activities that are happening at the University of Iowa right now. This is not fully inclusive of everything that's going on. The beauty of doing research at an institution like the University of Iowa is that you have opportunities to do funded research, whether it's through an organization like AFSP, the American Foundation for Suicide Prevention, or NIH, so the National Institutes of Health. All these agencies that can give money can fund research studies. And then you have opportunities when you're funded to work with other partners across the institution that you're in. So at the University of Iowa, we can do little mini projects with each other if we have overlapping interests. So some of the things that we're working on don't perfectly line up with something that's going on, but we've got some physicians that are doing genetics work, and then we have Dr. Fedorowicz who's doing some work in physiology, so health outcomes, and we can track people long term to see how the DNA methylation is affected by having a mood disorder. And so we're able to kind of work together on little projects that can then someday be funded, so we can do little pilot projects. The biggest thing that is important for you to know about research at the University of Iowa is that we have a registry, which is essentially a list of names of people who have said, I want to do research related to mood disorders. Please contact me if anything becomes available. So we have a website that you can go to and click through. I've got some brochures that explain a little bit more about what it is, but essentially if you participate in the registry, you provide us your name and contact information, and when a study comes up that might be appropriate for you based on your diagnosis or your symptoms, we contact you and say, we have the study, this is what it's about, would you like to participate? And then at that time you say, sure, I'd like to know more, let's find out about this. Or you say, no thanks, doesn't sound interesting, I don't have time, I'm not able to commit to that, whatever it is, you can say yes or no at that time. But if you are somebody you know is interested in doing research in the future and you want to be kept up to date on everything that's going on, just let us know and we can make that happen.
Yeah, in fact, the registry just makes it easier for us to contact you and let you know about opportunities, but it is not a commitment to be involved with any given project.
Right. So no commitments, just the opportunity to hear more about them. So that leads us then from research into clinical care and what is happening at the University of Iowa. And I think most people know that there are outpatient clinics that you can go to and have your medications managed. There are some psychotherapists that provide services through the University Outpatient Center. There are inpatient units that are available that are specialized for mood disorders, for geriatrics, for eating disorders, for general psychiatry, and we try to keep them specialized, but of course bed availability dictates sometimes that someone goes outside of their standard assignment. We have the partial hospitalization program, which Dr. Fedorowicz mentioned briefly about Dr. Epping. The partial program is an outpatient program where people with mood disorders or any other psychiatric disorders, of course we're focusing on mood disorders, come in from about 8:30 in the morning till about 3 p.m. in the afternoon, and they spend the day with a variety of different therapists. So sometimes there's music therapy, sometimes there's a cognitive behavioral therapist, there might be a mindfulness teacher, there's a physician that comes in and does education on medications, and then you also have opportunities to meet with the psychiatrist to check up on the medications that you're on as well. The typical person would stay in that program for about 10 days. Sometimes it's less, sometimes it's more. Most insurance plans cover it. But if you or someone you know could benefit from sort of what I call a boot camp, that might be something that you want to learn more about. And so for the folks at home that are tuning in, it can be a step-down program from an inpatient stay if you're not quite ready to be fully discharged and have very minimal support at home but need to have ongoing support, you can do this outpatient partial hospitalization program. It can be also a step up if you are currently receiving outpatient care but you need more intensive psychotherapy throughout the day, then you can step into this program as well. Let's see. So the specialty clinics is where things sort of start to get interesting. We have the Women's Wellness and Counseling Center, which has been around for quite a while now. I don't know when it was started.
I want to say 10 years.
Yeah.
Plus or minus a few.
Better part of a decade, probably. And they're really focusing on postpartum, menopausal, premenopausal, perimenopausal times as well, and how women's moods and psychiatric needs can change during those times. So they're really sort of focused on that. We also have, we're going to come back to that one. We have our neuromodulation clinic, which includes our TMS, which Dr. Erin Bowes runs, our ECT treatment team, which is Dr. James Beagley, Dr. Kiwan Nam are sort of the two, and then Dr. Aaron Crocker as well. And you had asked what ECT is, and I think Dr. Fedorowicz explained that ECT has been around for a very long time, and a lot of things have changed over the course of that time. If you are familiar with ECT as it stands today, you know that it is a very different approach than it was used even probably 20 or 30 years ago. So it's done under full anesthesia. There's a very present medical team that takes very good care of the patient. So if you are wanting to know more about that, let us know and we can discuss it a bit further. And then the other thing we're doing that I'm going to let Dr. Fedorowicz talk about is a treatment-resistant clinic that we just introduced a month ago or so. Yeah, brand new.
When I started, essentially. So I'm now doing a treatment-resistant clinic. This is for consultations, and so this is generally targeting folks that have tried a number of treatments and are still not having success. And what this involves is a very detailed and comprehensive history. We're looking for folks on clinician referral, so that if your provider is looking for more help or running out of ideas or just wants someone to take another look at things. This involves a very detailed consultation, so I meet with patients and family for about a half a day, and I spend about another half day reviewing records from the outside and put together a report that's probably usually about 10 to 13 pages that goes through things in great detail. It can be a reference for future providers. We are currently just seeing one person a week in this consultation clinic, and it's not for everyone. I don't think everyone needs this level of attention or detail, but there are some folks that I think are looking for new ideas. And so if this is something you're interested in, you can contact Amanda to set it up. We do want provider referrals, though, because I don't want to spend that time going into something unless someone is really looking for help or ideas. But we really want it to be a team effort. And so where your provider's looking for extra help and I can provide that help and in going through things in a way that they may not have time to in their ordinary practice. So this is something new that we're excited about and setting up. We're hoping to perhaps expand it at some point, but right now we're just in our first month of getting it off the ground. All right.
So the other exciting new thing that's happening related to mood disorders and clinical care is that we are in the process of creating a new inpatient unit. So if you've, has anybody ever seen an inpatient unit of a psychiatry department before? Most people have seen it in some way. We want to change the face of that as well as sort of provide a more healing environment. So we want somewhere when you come in, it feels therapeutic, it feels more comfortable. So we are building as we speak. It started in August. They sort of broke ground on the 7th floor to create, I know, right? To create a new inpatient unit specific for mood disorders. There are going to be initially 12 beds when it opens, hopefully this spring. And we actually are very fortunate to have a pretty big say in how it's being designed. So we're going to have 1.5 to 2 times more space per patient on the unit, so there'll be more physical space. They're all private rooms on the unit. We got special permission to adapt the outside of the building, so there's floor-to-ceiling natural light coming in all of the hallways, and there's windows in the rooms. We are doing a sort of more natural approach to it, so we're hoping to integrate some feelings of outdoors, even though we're on the 7th floor of UIHC. So the design aesthetic is going to be more natural. We're adding a destimulation room, which is going to be really helpful for people who are escalating, either because they're irritable or perhaps they're in the midst of a manic episode, or there's something that they don't require seclusion, they don't require being taken necessarily out of their space, but they just need a place that's controlled and destimulating to come down or to come up. And so we are working with our music therapy team or our occupational therapy team to really create a space that's going to be well designed to do exactly that. And we're going to add a dedicated exercise room, because most of the time when a psychiatrist sees you, they say, "Are you exercising?" And the answer is a variety of things. But we didn't really have an appropriate space for that in our past inpatient units and our current units, but we know how important it is. So we're adding a dedicated space for that as well. Anything else about that?
I guess there are a few design differences that might be distinct from other units too. So the nursing station is going to be open. So currently our standard design has been with like a plexiglass wall, and so this is going to be no such wall. So it's going to be open to the unit. So I think that people feel like that they have more access. There's going to be faculty, resident, and social work offices on the unit itself and not off the unit to make staff more available to patients that are on the service. And you mentioned the design elements, so we're really trying to make the design feel like a healing environment and a therapeutic environment. And so we've been working with some interior decorators to create a design that incorporates a lot of elements of nature. And so there'll be like sort of tree patterns on the walls and other things where there's really an effort to make it an aesthetically pleasing and soothing, comforting sort of space. So, all right.
Thanks. So education is one of those things where we have an opportunity to change what's happening in the moment and change what's happening in the future in terms of the type of care that's being provided to people that are sick. And right now our primary focus has been professional education. We have a lot of access to professionals in terms of residents and medical students and faculty members and staff members like social workers and nurses. We have access to that. We have some systems in place that allow us to sort of easily slide into those and provide that education. So we do things like grand rounds, which is where the entire psychiatry department or most of the people that are available at that time can come and listen to a very specific story. Oftentimes we bring a patient in, they're interviewed to talk about what their disease course has been like, what their experience has been like, and then we find a specific focus for that and talk about that in front of the entire faculty and staff. We have case conferences, which are monthly meetings of physicians and residents and some medical students. It's a much smaller group. About this many people, give or take, are there. We bring in a patient who is experiencing an acute onset of their mood disorder. So some of our patients have had manic episodes, some have been in depressive states. We interview them, we're given a history by one of the residents, a faculty physician interviews them, and then after that we spend about a half an hour or longer just dissecting the care that's been given so far, what some treatment recommendations might be, and really in a lot of ways just calibrating the kind of decisions that we're making so that if one doctor makes a decision about a treatment for the person, it's in line with what the other doctors would do as well for the most part. Dr. Fedorowicz does a lot of psychopharmacology lectures with residents and some medical students talking about which medications are the most appropriate for each diagnosis and each sort of subset of symptoms related to that. There are journal clubs that we add into. There are residents that do journal clubs, and so we talk in those. And then there are some psychotherapy for mood disorders lectures. Some of the psychotherapists that we collaborate with do some training and outreach and education there. And then eventually...
I do more psychotherapy lectures than I do psychopharm lectures.
Fair enough. And then eventually our goal is to have some sort of external sort of community-based mood disorder symposium. And so we haven't set a date for that. We haven't set up a specific agenda for that, but we want to have something that's available to the community that brings in experts either from the University of Iowa, sometimes external experts might be the person that we bring in, and we can tailor parts of it towards family members and people with mood disorders, and we can tailor parts of it towards people that work in the field. Maybe they work at the University of Iowa, maybe they work elsewhere. But that's sort of the bigger goal for how we're moving forward with that. So then, if you have a diagnosis of any type of mood disorder, there's obviously oftentimes medication prescribed, and that's one part of treating mood disorders. But there's a whole nother side, which is psychotherapy, and then support, whether it's through peers or professionals. And at the University of Iowa, we do have individual psychotherapists that can meet one-on-one with folks. Most of our psychotherapists specialize in one type of psychotherapy, whether it's DBT or dialectical behavioral therapy or CBT or ACT, which is the acceptance and commitments therapy. They all sort of dabble in a little of each for the most part, but they tend to be specialized. We also have group programs then. So at the university, we have a mindfulness program that does 8 to 12-week classes that focus on using mindfulness as a response to your depression or as a response to stress. We have a dialectical behavioral therapy program, which is an outpatient program where folks can sign up and join and meet to learn skills that are based in the dialectical behavioral therapy model to deal with strong emotional responses, depression, eating disorders, thoughts of self-harm. And starting on Sunday, we have a mood disorder support group. Yes, so we have several folks that are helping us with that. And we are really excited to be offering that weekly on Sundays at 4. I have flyers, so don't feel like you have to remember anything. This group is specifically for people with a mood disorder, so depression or bipolar disorder, excuse me. Eventually, we'd like to get into more family support. I was fortunate to be able to be trained by the NAMI family support group, family peer support group training. Yep. Great. So hopefully we can look at providing services to family members in concert with NAMI, so expanding the number of groups that they have by lending our hand, helping advertise, anything like that. So those are the big things that are happening. Oh, look, there's the information on the support group. I thought to put that in there. Very helpful. So it is located in the hospital, and if you've ever been in the hospital, you know it can be a bit of a beast to navigate. We are on the 2nd floor by elevator B. There will be laminated signs up that point you in the direction. We have convenient parking in ramp 1, free parking behind Kinnick Stadium. So a couple of options there. And if you have questions, there's no RSVP required. We'll see how it goes. Maybe in the future we'll need an RSVP. But hopefully we have a good, healthy, manageable turnout. That is the extent of the formal presentation. Does anybody have any questions? Great.
Have you ever thought in your new unit, your new inpatient unit, of doing some also integrative medicine, like with some Eastern touch to it? I was in a unit that was much like what you've described here in California, and one of the things that they did for me there was no medication, nothing the doctor could do, nothing a therapist could do could bring my heart rate down from 150. And it just kept going and going and going and going. They tried meds, they kept running EKGs. Then finally this guy came with the Tibetan singing bowls, and he had like 10 of them. And he came and he'd go in my room and he'd put them all around me and then one on my heart. And then he would do them and do them and do them and do them until I got down to 60 and stayed there. And it was really amazing. And it might be something somebody there would like to learn how to do. And
yeah, thanks for sharing that idea. We've been looking for all sorts of ideas, and in particular for the destimulation or relaxation room. I know one of the things we were looking at for that potentially was having aromatherapy available. I'm not sure where that's currently at. So, yeah. Okay.
I'm curious about something I've been reading about recently, and that is the use of psychedelics for depression, bipolar. Is there anything like that going on at the hospital, any therapy or research?
Have you heard about that?
Bill Corey. Yeah, so Bill Coriella is doing a study with esketamine at this time for treatment of depression. And there's no clinical use of it at this time at the university, but we do have a research trial.
You should ask if somebody else might have a question too.
Yeah, the reading I've done, I don't know if you're familiar with this, but But it has just blown my mind recently to understand the effects that can come from one LSD session or one MDA session with a therapist and the psychedelic that can be gotten on the street, unfortunately, because not too many probably research missions are happening in this country. But have you ever heard of the amazing results that can occur there?
There are a number of things that cause short-term improvement, but I don't believe that any of these studies have shown sustained benefit, and that's one of the issues that's been a challenge for the ketamine research, is that it shows benefits within a few hours, but those benefits are not sustained and only last for a few days.
Another question would just be for the group that's starting this week. Does a person have to be a patient at the clinic to come? Okay.
It's open to the community broadly.
Speaking of alternative drug therapies, is there any access to or plans for any research considering ayahuasca for increased insight in mood disorders and other psychiatric disease?
I'm not familiar with it, but if you have information, feel free to forward it. Feel free to forward it to me.
Okay, thank you.
I'm really glad that you're going to have an alternative to restraining people. It's been years and years since I was restrained, but I still have hurtful memories from it, and it just seems to me if you could be more creative, that would do a lot of people a lot of good.
We're really hoping to minimize that, and we're hoping that having private rooms and more space and a dedicated room for relaxation or destimulation and all of these things may help us avoid that at all costs.
I have a lot of questions. Okay. Would you ever recommend the stimulation, what do you call it? The magnetic, magnetic stimulation therapy for an anxiety disorder?
At this point, we don't have enough data on that, and so the trials so far have largely focused on major depression, which is why that's what the insurance companies will cover. But there is ongoing research looking to extend the benefits to other areas and to try to modify the technique. And so there's a lot of different settings and locations and ways to do it. And so which is very difficult to study because each one of those requires a separate study design to make progress. And so things are moving forward, but not as quickly as we'd like. But hopefully there will be broader applications for this.
I'm asking because my son has had anxiety treatment for years, to the point, and he's on disability, social service disability, for not being able to work or to really function well in society. And years ago, when he was seeing a private therapist in town, he had just gotten a brand new machine and put my son on literally weeks and weeks of that therapy, kept more and more, wasn't working, so I just wondered what the cutoff would tend to be in the way that you know more about it now.
Yeah, I'm not the best to answer that question. This is not a part I do refer people there, but it's not a part of my own practice. My sense is that they often do 2 weeks as sort of an initial idea, and then if there's some response, but not a complete response, they might push it further. But I think there's a certain point where if they're not seeing anything, that they just stop. And I don't know what the clinic is currently using as their threshold or guideline for that. But if you want to know, if you email me, I can talk to the director of the clinic and I can get back to you with a more specific answer too. And that goes for any questions that people are asking or not asking tonight. I'm happy to take questions.
I just wondered if he was having me help pay off his machine because he didn't discontinue, and it was distressing because it wasn't covered by insurance. And I also had heard that the university had a machine but was not using it.
We had one that was used for research for some time, but because it wasn't covered, we were not offering it clinically at all. And so now that we've made the effort to get this included in coverage, now it is available clinically.
Yeah.
I wondered if you had thought about pet therapy. Linda Hugg here has a whole zoo of animals. And when I need comfort, I go there, and the cat sits on my lap, and the bird is on my shoulder, pooping on me, and the attacked dwarf hamster is observed from a safe distance. And at my house, I have Mildred Millicent the Magnificent. Yeah.
We actually had someone come and speak to our clinical team, our sort of broad clinical team, about the use of pets for therapy pets and companion pets, and the difference, and they went through all of like the whole spiel about that. And I think that there's room for that within our inpatient unit. One of the things we always have to be mindful of is safety, and so we don't have a set program in place at this moment. But I think that there's, I might even think, is there anything now that where they bring in a companion? Yeah. So we do have some pet therapists or companion pets that do come in occasionally. So one of the things we can consider is how often are we doing that, and do we need to do it more?
I just had another question, and I totally spaced it out for a minute. If you're treating at the university over in like the the second floor clinic with somebody, and you have major depressive disorder, along with like other things like PTSD and things like that, do you qualify for the magnetic?
Yeah, potentially. The other diagnosis, as long as the diagnosis for indication is major depression, what comorbidities are with it should be fine. I mean, oftentimes our nosology, our diagnostic system is not perfect. We don't carve things out, so oftentimes people have multiple diagnoses. So an anxiety disorder with major depression is incredibly common, and that wouldn't be a barrier to getting treatment there. Yep. Yeah, if you talk to, if whoever's interested can talk to their provider, they can put a referral in and make things happen. Yeah, we're excited to have more opportunities, and I think also about opportunities being integrated together better. So, and we're going to be continuing to work forward in that. And again, please let us know what things you're most interested in or your priorities are, because Amanda and I literally sat down a couple months ago and tried to decide what were our priorities for year one, and we're going to have priorities for year 2 and year 3, et cetera. And so it helps us, the more information we get and the more we listen, the more likely we are to have these things line up with what people want.